Welcome to Cold Steel, the Canadian Journal of Surgery podcast, with your hosts Amir Farouk and Chad Ball. The goal of the CJS podcast is threefold. The first is to highlight the best research currently being completed by Canadian surgeons. The second is to offer educational topics for both surgeons and trainees alike. And most importantly, the third goal is to inspire discussion, thoughts, creativity, and career development in all Canadian surgeons. We hope you enjoy it.
Dr. David Notrica is a pediatric surgeon at Phoenix Children's Hospital in Arizona. In this conversation from earlier this year, we took a deep dive into pediatric trauma with Dr. Notrica from both a clinical perspective, but also from an organizational and systems level. Check out the show notes for the links to all the papers and guidelines we discussed in this episode.
Dr. Notrica, thank you so much for joining us on Cold Steel. It's an absolute pleasure to have you. And I know you're busy. You're at the Western Trauma Association meeting right now. So, again, we really appreciate it. Could you tell the listeners maybe a little bit about your training pathway, who may not know you?
Oh, sure. So, it's funny because you get asked, what exactly is a pediatric trauma surgeon? And the answer is it's someone who claims to be a pediatric trauma surgeon. The truth is I did my general surgery training at Emory, and so I was down at Grady 6 months a year, taking every third night call, and trauma was just completely integrated into my DNA as a general surgery trainee. And then when I went to do a fellowship and when I was in Houston, I had the pleasure of working with David Feliciano, and so you just don't get any better training than that. And then when I went to do my pediatric surgery fellowship, I went to Houston, Texas, at Texas Children's, and so once I got there, I covered pediatric trauma at Ben Taub Hospital, which of course is Ken Maddox's hospital, and so another 2 years of pediatric surgery, but also covering all the pediatric trauma for Houston. And so when I got done, the last thing I wanted to do was to take care of another injured child, and so I moved to Phoenix, where the pediatric surgeons didn't do pediatric trauma. And within a short period of time, it became very clear to me that my training background might have something to offer. And in 2008, I started the first level 1 trauma center in Arizona, the first pediatric level 1 trauma center in Arizona. And so that's kind of how I, got to the point that I am now. And along the way, there were some gaps in research, and some friends of mine whose names are household words in the pediatric surgery community said, "Hey, what would you guys think about doing some pediatric trauma research?" And that morphed into Atomic, and things just kind of went wild from there.
I love it. It's funny. You and I and folks like Neil Perry and Lorraine Tremblay, we're all biased, having been through Grady, but I truly will go to my grave with the belief that era, with you at the front of it and probably me at the back of it, or the four of us, was really the pinnacle of trauma training in the U.S., and we really couldn't have had it any better. I mean, every single day I do something that I learned there. It was a remarkable place at a remarkable time.
Yeah, and I didn't have the sense enough to appreciate it when I was going through it.
Yeah, so true, so true. Well, this is sort of a 30,000-foot question, Dave, to be honest, and it might be difficult to answer, but one of the jokes, of course, is that, and maybe it's not a joke, maybe that's unfair, but really that, pediatric medicine is not just, little kid medicine or little adult medicine. But, in that sense, what are some of the biggest differences, maybe biggest challenges between adult and pediatric care with regard to injury and trauma specifically?
So I can illustrate it with a story. And when I was doing my general surgery training, I had a fair amount of pediatric trauma during my general surgery training, and I had just finished a rotation as a chief, a third year chief, and managing pediatric trauma every single day. And I went back to Grady as a fourth year resident, and I was managing an adult patient with a grade 3 splenic injury that I wouldn't have blinked twice about on the ped service, and I nearly killed the guy. And this injury that was completely innocuous in kids and never would have required an operation, needed an operation in an adult patient. And I realized that that the reason that it's hard for most adult trauma surgeons to take care of injured kids is because they are just completely different entities. And so if you have this amazing skill set as an adult trauma surgeon, you know what needs to go to the OR and what doesn't. If you take that and apply it to kids, you're not necessarily optimizing what the kids can do. And the kids have proven that they stop bleeding, and they really stop bleeding a high percentage of the time. We're talking 97% of the time.
One maybe not even medical side to what I've observed from my pediatrics rotations, that the anxiety and emotional level in the room when a pediatric trauma case comes in, and maybe it's because in Canada we don't necessarily, thankfully, see the same level as maybe what you saw in Atlanta, but the anxiety level is palpable. And how do you manage that as a pediatric trauma surgeon, and how is that different from your experience working in adult trauma?
It's interesting because, and this is what happens when you get spoiled and work at a pediatric trauma center, is that anxiety just isn't there. And so, and part of the reason that the anxiety isn't there is because every single person in that room can identify a child who's in shock. So at an adult trauma center, there's a good chance that only the trauma surgeon is really going to be able to identify shock early in a kid. But at a pediatric trauma center, every single person in the room knows which kid is in shock and which one isn't. And so we spend a lot of time teaching and emphasizing that blood pressure is not an indicator of shock in kids. So shock is inadequate perfusion, and inadequate perfusion in kids manifests in paleness, delayed capillary refill, a high heart rate, and cold levels. You touch their feet and they're cold, and their pulse quality isn't good. And unlike adults who have a lot of reasons for having pulse quality that may not be great, in kids, if their pulse quality isn't good, they're in shock.
That's interesting. Well, you make it sound so simple, Dave, but one of the things I think that we all, ideally, I think, spend a career trying to do is condense the nonsense, so to speak, but really to try and make trauma care, globally as uniform and as high quality as we can. That's my adult comment. My observation in pediatric trauma outside of centers like yours is that it's even more variable. So what sort of advice would you have for these centers that don't see much volume and are trying to do their best, and maybe are housed with some really superb clinicians and fantastic people, but again, just don't have that volume that you live in every day?
That is a great question, and so I think that there are a couple of things that low volume centers that treat a low volume of kids can do. One is you have to trust your physical examination; it won't mislead you in kids, and so that is clearly one of the things that we all know how to do it, but we don't always trust it. And then shock index has been amazing. So what shock index does is it allows you to identify which patients are not really at risk of crumping, and so and that's a good portion of patients. And so when you look at the SIP or the shock index pediatric adjusted, I'm not even sure that you need that much adjustment. If your heart rate is higher than your systolic blood pressure, then you need to worry a little bit. And if it's not, your kid is probably not in shock. And so I think that is definitely something to lean on is shock index. And the nice thing about that is a lot of times people are really uncomfortable about knowing what a normal systolic blood pressure is for kids, and it's 65 plus 2 times their age. Well, yeah, that's easy for me, but when you haven't seen a kid in a year, you're like, what was that number again? And shock index doesn't need that number. You take 2 numbers and divide them, and if it's greater than 1, you're in trouble, and if it's less than 1, you're okay. And the pediatric adjustment basically says For younger kids, maybe 1.2 is okay, and and once you hit 13, then it's 0.9. But I don't know. I don't know. You need to memorize those numbers. I think if you can remember 1.0 and say, yeah, the heart rate's higher than the blood pressure. Let me worry a little bit more about this kid. I think that goes a long way.
And it's clear that you've done a lot of thinking about how to manage trauma, and it's clear from reading your CV that you have been very influential in just putting down the research as well to back up the way that you think. I'm particularly intrigued by the work that you did with Atomic and the stuff that came out of that, talking about managing pediatric blunt abdominal trauma non-operatively. Can you talk a little bit about how that came together, and why is it that or how did we come to this idea that we can manage a lot of pediatric trauma non-operatively, as you said?
I think that when by the time that the Atomic Group got together, a lot of us were having a little bit of frustration in that we had a lot of information, but we weren't applying it. And I don't just mean the adult trauma centers, which were taking care of the majority of the kids. I don't think that the pediatric trauma centers really had a concrete idea of how to apply this new information. And there was some groundbreaking research that had been done in Arkansas by Sam Smith that really said kids that are going to fail non-operative management actually show that very, very early. And we had kind of taken one direction with the APSA guidelines that I don't think it pushed things forward. It pushed things forward, but we learned a lot, and we didn't need to use that anymore. And so what happened was we got together and said, let's take the available literature and see if we can make a guideline that actually is easy to apply and useful and evidence-based. And that resulted in one of our early publications, which was the grade assessment that we published in the Journal of Trauma. And that was everyone getting together and figuring out what questions were important, putting together the algorithm, and we started with a general algorithm, and then we refined it, and it was an iterative process. And those co-authors on that paper worked really hard so that by the time that anyone outside of our group saw the algorithm, we had hundreds of hours of work making sure that algorithm made sense and was going to be useful. So the first algorithm that anybody ever saw was actually version 11 of the algorithm.
That document, I should say those documents that's come from that group, Dave, honestly, you guys are clearly very proud of it, and you should be, and you should go to your grave incredibly proud. They really did reset the bar for care of injured pediatric patients. They're unbelievable. Extending from that then, and I know this is, again, it's a 30,000-foot question, and it's probably really hard to answer, but for the chiefs doing their Royal College examinations or for the board exams in the U.S., if you were to condense really pediatric trauma care down to a handful of bread and butter pearl type statements, what would you tell them? Whether it's don't miss X or do Y. What are your thoughts?
Yeah, that's actually not a hard question. I think number one is 40 mils per kilo of blood products is a marker for a patient who is going to fail non-operative management and or going to die. And I think that that having that number in your head allows you to know when I'm going to not linger in that trauma anymore and when I'm not going to try anymore. And so I think that's a really good touchstone for successful non-operative management. And so if you say, well, I got a kid and they're in shock, if they haven't gotten 40 per kilo of blood or 4 units of packed cells, then maybe I should think about giving them some of that. The next thing that's most critically important is that a child that arrives in your trauma center from shock after a blunt abdominal injury, the only thing that you know is that they have bled. You don't know if they're still bleeding. And I think in the adult world, it's much more common that if you're in shock and have bled that you're going to keep bleeding. But that's not necessarily true in pediatric trauma. And a lot of those kids, a good portion of those kids get transfused and they stabilize. And they don't stabilize transiently, they stabilize forever. And I think that giving them a shot of a blood transfusion in the emergency room is good medicine. I don't think it delays things from most trauma centers. And I think that you'll find that some patients look a lot better after they've gotten a blood transfusion. So if they're in shock, give them blood. The other things, the last thing that's so critically important is to know that kids that fail non-operative management, they do it early, and they do it really early, probably within 4 hours of injury. And so the kids who are not going to do well, you'll know early. If you give them a challenge of blood and they don't respond to a blood transfusion, or they respond just ever so briefly to a blood transfusion, that's not a candidate for non-operative management. That patient's failed. And so if you have those touchstones, you know that I gave blood and they got hypotensive again, you're done. You know that you gave them blood and they stabilized and you haven't given them 40 per kilo, they're probably going to make it. Those really help you in clinical practice. And I think a lot of that is starting to show up on the exams as well.
Particularly in Canada, it's hard to come by a trauma laparotomy. And that's even in the adult world. And I think that's you get even less exposure to pediatric trauma operations. And yet when you do have to do an operation, both for adults and I'm sure for children, it matters even more that you're well trained. How do you envision us solving that paradox going forward? If you're a pediatric trauma surgeon and you don't have a pediatric practice, you're not going to have the skills to do it when you need to do it. And I think the same is probably true for a lot of trauma centers, which is that you do need that acute care surgery so that you're operating every day, so that if you do need to go into the abdomen and take out a spleen or pack a liver or repair a retrohepatic cable injury, that it hasn't been so long since you've been in the OR that you're confident and capable and able to do that. So I don't think that limiting your practice to trauma only at a place that doesn't have a high incidence of severe and or penetrating trauma is a good idea.
Dave, let me ask you maybe a little bit more of a controversial question. I can only imagine that setting up, from a mechanistic point of view, a level 1 pediatric trauma center must have been, I'm sure a pleasure, but also a bit of a nightmare. How do you, that's, maybe before I ask the question, I'll just state, obviously, that's a level of leadership that a lot of us probably can't fathom. So how do you generate that interest? How do you support that interest? How do you make that happen?
So you take every bit of political capital that you've amassed over the last decade and put it on the line, because the reality is that people will do it if they trust you, and people will do it if you can convince them that the reason to do it is right. And so when I went to specialties and I went to pediatric surgeons and said, yes, this is going to negatively impact your life. Yes, you're going to have to spend the night in the hospital to be a level 1 trauma center. I said, I explained the reason that you went into medicine and that you were given this great opportunity to operate on kids was to save lives, and you can make a difference. And let me show you how. And then we took the numbers of what the observed mortality was at the time and what the expected mortality was at the time, and showed them how in our catchment area, how we could make a difference.
It's amazing that very simple but powerful narrative was sort of enough to galvanize everyone forward. That's really cool.
Well, for most people that was enough. And then the other thing that happened was when we started to get pushback from specialties that really thought that this was going to impact them negatively to a point that would interrupt their lives. We had to listen to them. We had to when they said we don't want it, you had to ask them, tell me why, tell me what your concerns are, and let me see if I can mitigate those concerns. And everybody had a different set of concerns, and ones that I wouldn't have necessarily anticipated or assumed. You have to ask. So when the urologist started pushing back a ton about it being a trauma center, I'm like urologist, it's not that common of a thing. And they're like, well, we're worried that the trauma is going to constantly bump our cases because that's what we experienced during residency. And so we had to address that. We had to address how we could have a trauma center and not have it impact the elective surgeries. For the orthopedic surgeons, their biggest concern is that they couldn't get OR time. And so we had to address those. And so every specialty had different concerns. You have to ask what they are. And sometimes they're a little bit hesitant to tell you what their concerns are. Maybe they're worried that it'll be seen as self-serving, or maybe they're worried that it'll be taken in the wrong light, and so they don't necessarily want to be forthright with why they don't want a trauma center. But you have to push them, and you have to kind of get to the bottom of it. And once you start hearing what their objections are, then you need to make legitimate concessions and legitimate rules or resources available to make it so that those things don't come true.
Yeah, that's amazing. I mean, again, I'll just state it for a second time. I mean, that's a level of leadership, Dave, that is rare and it's unique, and you should be proud of it. Maybe the last question I'll ask you surrounds going to specialty meetings, whether that's trauma meetings or like adult trauma, whether that's peds meetings. I'm getting to know you now for a reasonable number of years, Dave, and in watching you at these meetings, I get the sense that you really deeply enjoy it, that you really find the benefit of going to conferences and interacting with folks. And I was just wondering, given that level of passion from your point of view, what do you see the benefits of these meetings as, not only at your relatively senior stage, but for trainees and fellows and junior staff and so on?
If you practice surgery your entire career the way that you do on the last day of your general surgery training or your last day of your fellowship training, you will not be doing a service to the people that you care for. And so the need for continuing medical education is real. And I've encountered surgeons who practice the same way they did when they finished their training 20 years ago, and those people are an embarrassment. Okay, you just can't do it. You have to go to the meetings. You have to see what's current, and not every idea that gets floated in a meeting is a good idea, but some of them are. And at some point, you have to realize that you've got to change with the times. The truth is that in 2020, there's almost nothing that I do the same way that I did in 1999. Now, laparoscopy was groundbreaking a change in the way we practice medicine, and laparoscopy kind of came of age in the 90s. And by the time 1999 came around, it was completely accepted, but not necessarily well done. And so, and so things had to change. And the critical view of safety for gallbladder surgery had not been described. And now it's like, not only do we do safer gallbladders, but we actually have a method that we can teach trainees that if you're seeing this view, that you're going to be a safer surgeon than if you're not seeing this view. And that's I don't see that that's going to change, for the next 20 years. I think that it was absolutely true 20 years ago, and 20 years from now, you're not going to be doing operations the same way that you are in 2020.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurge. Thanks again.